Thanks very much for inviting me. I think I'm going to learn as much from this afternoon as you all will from the speakers. So I'm going to tell you, before I start, I did want to acknowledge the traditional custodians of the lands on which we're meeting here today, the Kaurna people, and pay our respects to elders past, present and emerging. And I'm going to talk to you a little bit, quite similar, I was just saying to Alison, quite similar to her presentation, really about what I see maybe as the road less travelled. I think what you've heard already today is about people who have taken on almost new ideas and taken new careers forward, and certainly vaccinology is not something that was around when I did medicine. So I'm then going to talk to you a little bit about what my research is focused on, protecting children against life-threatening infections, and then the lessons learnt along the way. So, again, I was laughing with Alison, we might be related. So this is the Marshall family home, the farmhouse in a little town called Hockle in Northern Ireland, and 6 generations of farmers in Northern Ireland, and then my mum from Waterford, where the Waterford glass is made, but we are 5 generations of bakers. So how did I get to be a clinician researcher, spending really my time and energy and both clinical and research around preventing life-threatening infectious diseases in children? Well, I did medicine at Adelaide Uni, you can see me there highlighted. And again, I think it's our medical electives that sometimes give us the inspiration and the passion for what we end up doing. And at the time, it was really popular to go to Great Ormond Street or, some fabulous hospital somewhere around the world. But I actually wanted to go somewhere where I could get some practical experience. And I knew going to a country which was more of a sort of low resource country, that I would get more opportunity to have practical experience, as opposed to in those other hospitals you're often sort of number 30 person on a ward round. So I did that, and I was put onto the paediatric ward as a medical student, and really with very little supervision. So I had a GP that would come in once a week and a retired paediatrician that I could call if I was really stuck. So it was pretty much learning paediatrics on the run, and I saw children who got very seriously unwell. So this is a child that's about 15% dehydrated from gastroenteritis. The women's and children's, they might be 3 to 5% dehydrated. And once you get that dehydrated, a child can obviously end up dying from dehydration. And this was the ward, the fridge on the ward where the medications and vaccines and things were kept. So I got amazing experience in putting in IV lines into feet. They're so dehydrated you couldn't see veins anywhere, and also on the scalp. And I came back very experienced in doing lumbar punctures, all sorts of practical procedures. And so I loved the experience, and I loved working with children. And so I got into paediatric training, so that's what I wanted to do. And I was lucky at the time because usually they didn't take you from your intern year. You had to do a year in an adult hospital. But I think just because I came back with all that experience in being able to diagnose and treat children from my medical elective, that they accepted me into paediatrics. And I was obviously looking after children who had serious infections like this baby here who has meningococcal disease. And it's one of those diseases that really stays with you, which I'll explain in a moment. And I was asked by the Professor of Paediatrics to come and do some vaccine research, that they were undertaking the first vaccine trial in the department. And that's how I got involved in research. And I realised then that I really didn't have the skills I needed if I wanted to keep working in research as well as clinical medicine. And so I undertook a Master of Public Health. And the Master of Public Health gives you basic epidemiology and stats skills. And then I chose to do the advanced stats subject, and people like Phil Ryan would laugh at me, but it did give you a bit more understanding of how to do some more complicated statistics. And it was when I was doing that Master of Public Health that I had one of those light bulb moments that although I love treating patients, children, individual by individual, it was really the impact that you could have if you were doing research that was being used to make good policy that could improve child health at a population level. So it was very much about combining medicine, my clinical perspective, vaccinology, which I was learning about vaccines and the science and development of vaccines through the research I was doing in the Department of Paediatrics, and then public health, which I found really inspiring about changing the health of children at a population level. And I've included there that partnerships, and we've already heard about partnerships being so important already today, that it's really my clinical research career has been about the opportunity to work with people across academia, government and industry. And that photo there is from our Be Part of It study, which I will go into, but you'll see there we had the people from government, we had the CEO of the Women's and Children's Hospital, the head of a department, the director of the Robinson Research Institute from the university. We had GSK providing the vaccine and funding for the study. So we actually had their president of vaccine development from Europe out, and I was getting everyone to dab. I don't know whether anyone remembers dabbing. So dabbing was kind of popular in 2017, 18. I was getting them all to dab for their jab, so it's a bit of a funny one. So you can have a lot of fun as well. And then in our study in the Northern Territory, there's the Health Minister launching our study with James Ward, who is an Aboriginal researcher and a very close colleague. So that's a bit about how I got to where I am, and then a bit about the research that I do. So I mentioned to you that working, at a children's hospital, meningococcal disease is really something that stays with you because it's a really serious infection, even though it's uncommon. There is still, in 2022, there is still a 5 to 10% chance of a child dying from becoming infected, which is pretty unbelievable. Even if you get the antibiotics in quickly, they can die within 24 hours. And although about half of them do recover without any problems, the other half have significant complications. So this child here has ended up with, and you can see there where the limbs are going dark, has ended up having surgical amputation of all 4 limbs. So the disability that creates going forward, it's really a really nasty infection. They can have deafness and blindness as well. So meningococcal disease was always something I was interested in, and I have to say, I was working in the department. We now had meningococcal vaccines that were going through. We were working on phase 2, phase 3 clinical trial development. But it was really when my daughter rang me to say that friends of ours, son Jack, was in the Royal Adelaide in intensive care on life support and had meningococcal disease. And Jack had been playing football 48 hours before that, and you'll see photos of that there. And he became unwell and then was on life support and died within 24 hours of becoming unwell. And although as doctors, we're trying to be objective, when something happens, I think at a personal level as well, it gives you that kind of passion and drive to try and make things better, because I did feel we'd let Jack down. Why didn't we have meningococcal vaccines available sooner? It's a little bit like COVID. When you've got a pandemic, everybody races to get a vaccine available, but because it's an uncommon infection, it had taken longer for these vaccines to be developed. So we now have, so for those who maybe don't know so much about meningococcal disease, it causes meningitis or sepsis or septicemia, and the highest rates are in the infants and adolescents. South Australia had the highest rates of meningococcal disease in Australia, and most of our cases were due to the B strain. And you may not know, but about 10% of adolescents carry the meningococcus in their throat. And we now have meningococcal ACWY vaccines available in our schedule, and at the time, meningococcal B vaccines were becoming available but not included in our immunisation program. So talking about going overseas, I happened to be at an infectious diseases meeting in Europe where the head of meningococcal vaccines in the UK, they'd just introduced Men-B into their infant program, and he was presenting, showing that the vaccine was effective when you implemented it in a program in the UK. And so from our conversations afterwards, I went up to have a chat to him about this. One of the really important questions that still hadn't been answered about the meningococcal B vaccines was whether there was a herd immunity impact. Because if you can stop the disease, but you can also stop people carrying the bacteria and stop them transmitting the bacteria, then you're going to have a herd immunity impact. And hopefully everyone knows about herd immunity now after COVID. I don't have to explain that concept too much. So they were discussing in the UK about doing a herd immunity study, and really what I was doing was advocating for South Australia to be really the best place in the world to do a herd immunity study. We had the highest rates in Australia, which were high, compared to other countries as well. Most of our disease was B. We had a school immunisation program that could deliver, the nurses could deliver the vaccines through the schools, and we could do it really quickly, really efficiently, because we kind of all collaborate. I mean, Steve will probably remember when I was first trying to think this through, I rang Steve, I rang our executive dean at the uni at the time, I rang Paddy Phillips, in SA, the Chief Medical Officer in SA Health, because I just wanted to make sure that I was getting excited about something, was it really achievable? And everybody was on board, everyone's enthusiastic, let's go for it. So we undertook a cluster randomised controlled trial in South Australia. It was sponsored by the University of Adelaide, funded by GSK. It's the largest study of its kind anywhere, and we enrolled 35,000 senior school students in 3 months across the whole of South Australia. So 62% of Year 10 and 11 students across South Australia, not only metropolitan Adelaide, but rural and remote schools got involved. And we had, again, it's about partnerships and involving everybody. We had youth advisory groups advising us. These are the amazing immunisation nurses we trained who went back out into the community. And it was a very successful study and published in the New England Journal of Medicine. And I don't have time to go through it in detail, but just to say that our main finding was actually there is no reduction in carriage, and so we can't expect a herd immunity benefit from this vaccine, but the vaccine is highly effective against disease in adolescents. And we had a kind of unexpected finding. Although it didn't have an impact on people carrying the types that cause disease, we did see a significant impact on unencapsulated meningococci being carried in the throat. And if you look, I don't know if I've got a pointer, but at the same time that we were doing this study, New Zealand had been doing some research looking at outcomes from their meningococcal B program. They did in the early 2000s, looking at the impact of the vaccine on gonorrhea. And you might think that's a bit strange. They're both very clinically different clinical diseases, but they're actually very closely related bacteria. They come from the same Neisseria family, and they'd actually shown an impact on gonorrhea. And so a finding from our study, knowing that and I should say the gonococcus, the difference is the gonococcus doesn't have a capsule. The meningococcus, about half the strains that are carried have capsule. They're the disease-causing ones, but the rest don't have a capsule. And we found that in our study of carriage, that the vaccine actually reduced the meningococci without the capsule. So it was a way of kind of understanding why we might be seeing this impact on gonorrhea. That if you don't have a capsule, you don't have that blue bit there, the proteins are more exposed, the antibodies from the vaccine can bind and destroy the bacteria. So we're very interested in that whole concept around gonorrhea as well. We did, as I said, we did show a reduction in meningococcal B disease in adolescents, which was the first time that's been reported anywhere in the world. And then at that time, the Health Minister decided we should have a meningococcal B vaccine program here in South Australia for infants and for adolescents. And so I was asked to be part of that group to come up with how we should put that program together. What's the best way to do that? We knew there was not likely to be a herd immunity impact from our research. So our study was really saying you have to have the vaccine to be protected. You've got to give it to the highest risk groups for direct protection. You can't expect a herd immunity impact over time. And so what we did is we looked at age-specific notification rates, and you'll see there that meant that we had a big program. So anyone under 4 was included in the MenB program, and 15 to 20-year-olds. We were then asked by SA Health to measure the effectiveness of the program here, and we showed it was highly effective in infants, highly effective in adolescents in reducing meningococcal disease. We did these, fancy case control and price on regression, but actually I think that graph just says it all, down to 4 cases after that program was introduced. And then, of course, we're very interested in the question about gonorrhoea, and so we looked at the effectiveness of the MenB program here in adolescents against gonorrhoea, and show very similar vaccine effectiveness as they'd shown in New Zealand. And we also showed a reduction in gonorrhoea in that 15 to 19-year-old age group. That was not significant, and the problem, it's not a problem, it's a good thing, we don't have a lot of cases of gonorrhoea in 15 to 19-year-olds in South Australia. So we were kind of looking at where it might be good to look at measuring that in a more definitive way. When the Health Minister, we provided all our data to the Health Minister, who made the decision based on our findings that the MenB program will continue indefinitely in South Australia, which is a good thing. So we were looking at where we might find gonorrhoea occurring in the same age group as we were trying to prevent meningococcal B disease, and that happens to be in the Northern Territory. So in the Northern Territory, the Northern Territory has the highest rates of gonorrhoea in Australia, and the highest rate is in 15 to 19-year-olds. So we have taken the B part of it study in South Australia. We had NHMRC funding and a partnership grant working with SA Health and NT Health to do the study in the Northern Territory, and we're up to about 2,000 recruited to that study at the moment. The burden for gonorrhoea is really in infertility, and in women, about 80% of infections are asymptomatic, so they don't even present to get treatment, and if they've had 3 or more infections, there's a greater than 50% chance of infertility. So in the Northern Territory, 15 to 19-year-olds receiving the MenB vaccine, particularly for Aboriginal and Torres Strait Islander, where the risk is very high for both. We really have the opportunity to close the gap through using use of this vaccine. So that's been most of what I've been working on at the moment, that is showing how the research that you can do can inform policy decisions and have really good outcomes. But I've been doing lots of COVID stuff. As you can imagine, if your area is in vaccines and there's a pandemic, there's probably going to be a bit of work to do. So providing advice to the Vaccine Implementation Strategy Group, to the Chief Medical Officer and Chief Public Health Officer. We're doing quite a bit of research looking at what's the best schedule, so which is the best heterologous schedule for COVID vaccines going forward. And as mentioned before, just taken on the role of Clinical Research Director, really looking, and that's, I'm very pleased to be here, looking at research strategy for our network, establishing a research centre and research symposium for the network, and thinking about the new Women's and Children's Hospital going forward, and having research embedded across all our health delivery across the network. So just some lessons learnt along the way, because I've been interested in the questions that have been asked so far. So I would say, do what you're passionate about, because that's where you'll really have the greatest impact. I think that's what the other speakers were saying as well. Then you'll enjoy it. You can actually have some fun along the way. And even if you are very busy, it keeps you going because it's something you're passionate about. The research that you do will improve clinical practice, health service delivery and policy. And really important, and I've just got a slide following on from this, about negotiating, protecting research time. I was really lucky that the head of the department asked me to come and do some research, and I was able to do that in my clinical time. You won't always get perhaps that same approach. But that's certainly something I'm talking, in my new role, talking to heads of departments about, making sure that the clinicians within the department has allocated research time. For me, it was about then actually getting NHMRC funding fellowships so that I had definite time that I could allocate to my research, which I've been successful in doing, which has been great. Join networks. The networks was the other thing I was going to mention, someone asked before. Even as an early researcher, join clinical or research networks in your area of interest, because that's a really good way of getting involved in a group of people that are like-minded, that are successful with doing research, and it will teach you how to do research. Training, you know, I think it was really important for me to do the epidemiology and the stats to really expand my research. And, you know, that can be from workshops through to doing PhDs. I know it's easy to say be in a supportive research environment, but do try and, you know, work somewhere where you do have organisational support. It'll be far more enjoyable for you. And if you're not getting that support, you know, do something about it. I'd say take risks in what you're doing, but calculated risks. It was a big risk to take on a statewide study, but, you know, you get the support from other people at all levels. There's no reason not to do it. And be willing to share and collaborate. And I think, you know, don't hold on to your own data in your own little siloed bit of work. Make sure you share that. Just try and be generous, and you'll get that back. And try and do that nationally and internationally. One of the things I do with PhD students is say, find an international, someone in your area that's publishing internationally, and invite them to be on one of your papers, whether it's a review or something that they can contribute to. Then you automatically have an international collaborator. Mentors has already been discussed. Find someone that you trust, and build a multidisciplinary team. You know, have medical, nursing, scientists, allied health as much as you can, and by supervising you can actually build that team. And I put down the bottom here, which probably should be up the top. I think relationships are so important, and they underpin everything that you do and that you want to achieve. So always strive to have, you know, good relationships and listen to people in everything that you do. So protected research time, I think I've sort of covered that really. You know, negotiate that, but you might have to, you know, it's great if you can get a fellowship to protect that very well. Attend international meetings. It's really those in-between conversations between, you know, we talked about it before, plenaries, that you come up or can come up with good research ideas. Collaboration, start early. Don't wait for people to ask you. Make sure that you are actively initiating collaborations and partnerships. Put your hand up for being on hospital and government committees, because you'll meet people that will be important to have as partners potentially in the future. And don't be afraid to give talks and take up media opportunities to, you know, which is good for the community to understand what you're doing, but it's also a good opportunity for them to understand what your research is about. And I obviously have a research team. I don't do it all by myself. I only started with one though. I started with one research assistant, and now we're up to 22, a very multidisciplinary group. And this is my last bit really, but funding's a bit boring, I know, but just make sure that you can try and use diversity in funding sources. Some people think, oh, you can just do drug and vaccine trials. There's no way that covers a research program. So really just to finish up and to say, because you never know where you might, I certainly did not expect to be speaking to ScoMo at the Australia of the Year Awards in January. That's my family, and again the comment about family, how important family is. You know, so you absolutely can fit a family in. And I was trying to convince him there that we needed to have more research for COVID to be able to answer the really important COVID questions that ATAGI needed the answers to. I'm not sure how successful I was, but it doesn't matter anymore anyway. Okay, and that's it, and that's why I do what I do. Keep kids out of hospital and keep them healthy.